and different time here. Welcome to our channel. My name is Saint-Clair Bernardes. I'm a physical therapist from Brazil, and I work in the acute care setting of the physical therapy for over 15 years. And the purpose of this channel is to exchange experiences and bring together physical therapists from different places. And with that, we can provide a channel for discussion and make better our profession. And I would like at first to take the opportunity to ask everybody to subscribe to the channel so you can follow all the future projects that are yet to come, and also to watch the videos that we have already loaded at the channel. And after the success we had from the first webinar about the ICU physical therapy, dealing with COVID-19 patients, where we had the opportunity to talk to professionals from Brazil from different areas and change experience with them. Today, we're going to have the second version of the webinar, and we're going to receive some physical therapists from different places from the world. So we're going to have different countries represented here by physical therapists that are references in this area for a lot of people that work in the ICU setting, the hospital setting. At this time, we're going to discuss about what we have learned about how is or how was the setting of the ICUs with COVID-19. And I think that we're going to be able to share a lot of interesting things. I'm very grateful to have our colleagues here, and I'm going to start present them so after that they can start speaking. And I would like to thank, first of all, them to participate in this webinar and being available today. I have people that just started their workday and people that are almost at bedtime, almost no, people that are after bedtime working here with us today. So thanks a lot. Your contribution in what you're going to share here is very important for the profession and probably is going to help people to provide better care and better results with patients in the ICU that have COVID-19 in this delicate situation that we're experiencing today. So today we're going to have we're going to have here joining us in this conversation, Daniel Ludwig. Daniel is a physical therapist at Johns Hopkins Hospital in Baltimore, the United States. He's a specialist in neurology. He's a doctor in PT and a teaching member of the physical therapy residence in critical care and neurology at Johns Hopkins University. We are going to also have here the participation of Heidi Engel. She's a physical therapist at the Surgical Medical ICU at the University of California in San Francisco in the United States. And she holds a doctorate in oncology and integrative medicine from the Boston University. And she has formation with ICU Interprofessional Group. And she is a graduate professor at the University of California. We are going to have also Peter Thomas, who is a physical therapist and a leader of the physical therapy team in the intensive care and general surgery at the Royal Brisbane and Women's Hospital at Queensland, Australia. And he is a specialist in cardiorespiratory physical therapy, and he contributes to the multi-professional education in the ICU and in a lot of forums in this area. And also we're going to have here to talk with us Vitor Azevedo, that's a physical therapist from the ICU of the Hospital Egas Muniz in Lisbon, Portugal. He's a doctor in PT also, and he teaches at the School of Health of Alcoitão, and is a lecturer on respiratory physical therapies and early mobilization, mechanical ventilation, and ultrasound in the ICU. Well, once more, thanks a lot, all of you, for being here today to share your experience. And to get started, I think at this first moment, I would like you to make your initial speech, and you can finish presenting yourself and then telling us a little bit more about your work, about your setting, about your ICU, about your service, and about how it has been the experience with physical therapy in the ICU with COVID-19 patients. I'm going to ask Daniel to start with his presentation. Hi, Daniel, welcome. Thanks a lot for being here today with us.
Thanks for having me. I'm really honored to be able to speak with all of you and share some of the experiences and compare and contrast some of the experiences we've had from across the world. So just a little bit about me and where I work. I'm from Johns Hopkins Hospital in Baltimore, Maryland. We're a large academic medical center, and we have typically over 1,000 inpatient beds. on a regular basis. And our acute care therapy department consists of over 60 therapists for PT and OT and speech language pathologists. A little bit about how COVID affected us. Typically, we have 6 ICUs that are broken down into specialized ICUs, whether that be neurologic or neurosurgical, cardiac or cardiothoracic, oncology, a general medical ICU. And very quickly, in March and April, our ICUs were becoming overrun with COVID patients, and we quickly switched from 6 specialized ICUs to changing to 5 ICUs that were strictly treating COVID patients. So it was a big shift in practice for a lot of people who work in certain areas and spend a lot of time treating patients in a little bit more of a specialized setting, to having to quickly learn and adapt to a new diagnosis that was quickly overtaking our ICUs. Some of the things that we did were work closely with our physiatry team and our intensivist teams to come up with a plan as to what the best response was going to be for our therapists going into the ICU. We have a lot of training for our therapists. It's part of their introductory competencies when they are hired, that they train in the ICU. So most of our therapists are comfortable treating patients in the ICU. And so it wasn't necessarily an issue of training therapists who typically do not treat in the ICU to be able to go treat patients there, but to teach them what the most appropriate interventions and use of PPE and which patients were the most appropriate to see in those units. And so it was reframing their mindset in terms of how they were treating their patients and what we were doing. In doing so, we talked about what were appropriate consults, and for some of our patients with occupational therapy and splinting needs, as well as higher functioning patients, we were able to create an algorithm based off of fall risk scores, basic cognitive testing, and mobility scores that nurses help us to score within the hospital to determine whether patients might be appropriate to be seen using telehealth services within the department. And that was a really good way for us to be able to more judiciously use PPE, not expose, especially initially, as many therapists to the potential virus at the beginning, before we really knew how effective the PPE was really going to be. And that was one of the big questions is, we don't know how effective this PPE is. We don't know much about the virus, and we don't know how infectious this is going to be. Is there a way that we can maintain some of our services but decrease our exposure? So using those tools to help determine if patients were appropriate for telehealth services was one of the first things that we jumped on to be able to try to manage those things effectively. In working with those other therapists and physiatrists, and as our ICUs quickly became full with COVID patients, we slowly had to integrate more and more therapists into the care, especially if they were covering on weekends and covering in areas that required them to see COVID patients. And so at some point, we had almost every therapist in our department trained to go into a COVID unit. And what that entailed was going with a super user to be trained in the appropriate donning and doffing techniques using the PPE, so that we ensured that our therapists were doing so safely, going into the ICUs where the COVID patients were being treated in a safe manner and decreasing our exposures as much as possible. So a lot of what we're talking about is the unknown. And so one of the things Saint-Clair asked us to sort of speak about at the beginning is, what did it feel like as a therapist treating COVID patients? And there was so much unknown going into this. It was a bit scary, right? The first time you walked over to that ICU and you went through the procedure of putting on your mask or putting on your PAPR and putting on all of the gowns and the extra gloves and all of those things, whether or not it was yourself or walking somebody else through that process, it was nerve-wracking. And then at the same time, we didn't know what these patients were going to present like. This was a new, novel diagnosis, and we weren't exactly sure how aggressive or not aggressive we needed to be with these patients. We gathered information quickly, and again, collaboratively with our other colleagues in the hospital, and updated our staff as we needed to through quick tip sheets that were one-page emails that they could carry around with them about what we knew about the diagnosis, how these patients might present, what some tools or measures that they might be able to incorporate into their care might be, so that therapists who have less experience with some of these ARDS type situations were able to go in and more confidently treat these patients outside of all of the other issues with donning and doffing PPE and things like that. And as we were sort of talking about before we came on live, all of the areas that we work in did a really excellent job of getting information out from professional organizations early and often as soon as we knew updates. And so we were able to direct therapists to webinars that were occurring or publications that were coming out throughout the spring to keep them informed and keep them up to date with what the best practice would be when they were treating these patients. And the last thing that I really wanted to emphasize in terms of what COVID meant to us as a hospital and as a profession was it really showed me what we can do with our collaboration and how creative and adaptable physical therapists can be. We figured out ways to appropriately treat patients, came up with interventions that were appropriate for patients who were not able to leave their room, but who were progressing along the continuum of care. We worked closely to update our delivery of care, recognizing that patients were not going to move through the continuum at the same pace or rate, given the infectious nature of the disease. And so updating how frequently we were seeing patients, the interventions we were using with them to be able to assist in transitioning those patients home more quickly, as opposed to having to wait on them going to some type of intermediate rehab care. And so adaptability and creativity throughout this process really blew me away, not just within my own department, but across the face of physical therapy, to be able to rise to the challenge that this pandemic presented to us and do so in a really time-efficient manner.
Okay, Daniel, thanks a lot. And that's really interesting to hear all that. And especially when we start hearing different stories and we see that we all had to take the same ways to improve the assistance of the physical therapy and to change the way we deliver physical therapy for these patients being effective anyway. So that's really a challenge we have, and that's good to hear. So now I'm gonna ask Heidi. Heidi, tell us a little bit more about your experience, and if you want to finish presenting yourself. Thanks a lot for being here with us.
Oh, thank you so much for having me, Saint-Clair. So I am at work today. It's 3 o'clock in the afternoon on a Thursday for me. And so here I am. And I just came out of the ICU. So I have my COVID hairstyle and everything. So it's a little horrifying to be on a screen. It's the most challenging work I've ever done. And I have been a physical therapist for 33 years, okay? And I've worked in oncology and I've worked in hospice, and I was the founder of our ICU early mobility program at a large academic university teaching hospital. So I have worked full-time in the medical surgical ICU, where we have, you know, the tertiary care, the complex patient population, all the transplants. We're the #1 lung transplant program in the United States, just as an example. So we have pretty complex patients, and I've been there for 10 years, full-time in the medical surgical ICU. So we saw this coming, and we don't have the wealth of resources that Johns Hopkins has. I am perpetually jealous of Johns Hopkins, and if I could ever be Johns Hopkins, I will feel like I've really achieved something. We have no physiatrists. We have no department of physiatry, and in the whole state of California, post-acute rehab and acute rehab is very different than on the East Coast of the United States. It's pretty weak as a resource and it's pretty limited. We really don't have near the same level. And I'm from the East Coast, even though I have lived here for 32 years. So I have a bit of a sense of comparison. When COVID first started, so first of all, I also have to say that San Francisco is a little island. We are a little bubble in the United States. So we're a major city, but we've never had a COVID surge. So even though you hear that California right now has this very high rate and high incidence of COVID patients, it's not happening in San Francisco, and it hasn't been happening in the city of San Francisco. We've had a pretty steady stream of in our hospital, not even our ICU, we've had like 20 to 30 COVID patients from the beginning of March until now. And several of our ICU COVID patients are not from San Francisco at all. We are accepting transfers from pretty far away, from the counties that have had much greater impact. So there's actually a lot of hospital beds in the city of San Francisco, and the city itself has not experienced a surge. So San Francisco shut down very quickly. I think San Francisco is a model for how much of a public health issue this really is, how it's not a medical problem. COVID is a public health problem. And right now, if you want to fix the public health problem, you have to maintain all of the precautions that we know so well. So San Francisco started doing that before anywhere else in the United States. And we had the luxury of being able to do it pretty easily and pretty well initially, because our big business is tech, right? So we are where Google and Apple and Facebook and YouTube and every single one of those companies, you know, they are based here. And that's how everyone earns their living here. So if you told all those people to stay home, it was absolutely no problem for them to stay home. And they all got told to stay home at the beginning of March, well before the rest of the United States shut down. San Francisco also tends to be very community and civic oriented. So people have been very adamant about wearing masks, unlike other parts of the United States where people will yell at you for wearing a mask. In San Francisco, people will yell at you if you don't wear a mask. It's a very weird situation. But on top of that, so since we have not had a surge of patients, since we are a lung transplant center, an ARDSNet ARDS research center, we had a lot of experience in treating people with severe ARDS before this happened. And we have a very robust respiratory therapy department and respiratory therapy service. We're very spoiled. So as a physical therapist, my only job is mobility. I don't have to prone anyone. I've never had to prone anyone. We had a proning team, again, well before COVID started. And we had a proning protocol, and we were proning before COVID started. So it was like, and we never had a surge of patients. So it was like, oh, we have to prone some people. Okay. And the nurses and the RTs prone the people. I've never had to prone anyone. The RTs do it. The RTs manage the ventilator. So, and they do a fantastic job. I think one of our greatest barriers initially was all the fear and all the unknown about would we run out of PPE. And therefore, initially, some of the nurses looked at us, the therapists, even though I've been there for 10 years full time, and they said, we don't know if you should mobilize these patients. We don't know if you should waste the PPE. Again, all the research and the data we initially had was from China, where if you ended up ventilated in the ICU, from their data, it said 80% of those people were going to die. And then we had other data from Italy, and that data said 50% of your ventilated people were going to die. And so in the very beginning, there was a thought of, well, why bother mobilizing them if they're going to die, right? And then they didn't die, which was fantastic. And not only did they not die, but we've had a very consistent less than 10%, more like 5% mortality rate in the patients we've had at UCSF. So I think it's because we had no surge, we had the capacity, we had a deep, well-trained staff, we had no problems having ventilators. We've had ECMO here forever because we're a heart transplant program, and we've certainly treated ARDS in the past with ECMO, but we've done no ECMO on any of our COVID patients here because we haven't felt they needed it. And we have done very few trachs. We have not done too many tracheotomies, so we have not been early tracheing people at all. Yeah, and our sickest patients don't come from here. They come from the Central Valley of California. And I will be very honest with you and tell you that pretty much 90% of my COVID ICU patients are Latinx. So they're all Hispanic. They all speak Spanish. The job is so exhausting because we have negative pressure blowers in the room, very noisy. I have all the PPE on. We've got the vent. We've got everything going. I'm trying to scream at a person in Spanish and my Spanish sucks. So then I get a video screen interpreter up next to the patient, and the screen and the interpreter can't hear and I can't hear. And I just scream all day long, and it's exhausting. But when we get patients past the hump, and it takes weeks. So we weren't used to in the beginning that it would take weeks of intensive critical care and horrible boatloads of sedation that we'd spent years pulling back on. And then they come out of it, and they come out of it in this pretty bumpy way. They have good days and bad days and horrible, you know, all this stuff happens. They get tachypnic and tachycardic and everything else. And then they come out of that and they miraculously get so much better. So we can then really intensively rehab people, and they walk out of the ICU and they walk down the hallway on the regular hospital floor, and then they go home. It's crazy.
Great. It's really great, Heidi, to hear another different setting, another different experience. And one thing that you highlighted at the end that's really interesting is that this patient, they get severe damage from the ICU, but they are also, how can I say that? They are able to be recovered in a fast way. So that brings much more importance for the physical therapy, for the acute care rehab. And we're going to discuss a little bit more about that. Okay, great one, great talk. Peter, let's talk to Peter right now. Peter, tell us how is in Australia and how is your scenario, how it has been your experience with COVID-19 physical therapy.
Sorry, forgot to unmute. Thanks, Saint-Clair. I feel very fortunate being in Australia and an Australian because we have been relatively protected from COVID in terms of numbers in comparison to many of the places that you're from. So my actual workplace, I'm in the Royal Brisbane Hospital, which is Queensland's largest hospital, and it has close to 1,000 beds. And we've got care across a range of conditions. We're a permanent cancer centre. We do maternity, trauma and burns care. We don't do transplants, but we don't do coronary surgery, but we do pretty much everything else. The physio department I work in is actually quite large, but we're probably because we include a lot of our rehab services within our acute care facilities as well. So we have 120 physiotherapists, so they're about within our department. Our intensive care is the 4th largest in Australia. So it's 22-bed intensive care with 6-bed ESHG or high dependency unit, which is predominantly for post-surgical patients. And our normal surge capacity just on a day-to-day basis, so it wouldn't be unusual for us to move that bed number up to 36. We've got 36 physical bed spaces, so we will actually increase our numbers even prior to COVID. With our COVID surge capacity, our ICU was actually able to go up to about 54 beds with putting 2 beds in each bed space. And then there's capacity then to move out into theatres and things like that as well. Our hospital's only about 20 years old, so it was redeveloped and we moved in just after 2000. So the style of the unit is with 7 open bed bays and 2 isolation rooms in a pod, and we've got 4 pods of 9 beds. So we're actually pretty shy on isolation rooms, as opposed to how many ICUs are built these days at being all isolation rooms. And that in itself is posing problems in terms of our capacity and how we move our COVID patients around as we move through various stages. In terms of our Australian experience with COVID, as I said, we're very fortunate. Overall, we've only had in Australia just over 22,000 cases and only 361 deaths throughout the country. Our initial first wave in mid-March to mid-April, the patients that came to our hospitals were mainly from overseas arrivals. We've got a second wave now, which has sort of just occurred since July. And again, very fortunate being in Queensland because this main second surge has occurred in Victoria and a little bit in New South Wales. So that's where the large volume of patient admissions to hospital and ICU are occurring. So in Queensland, we've had a lot of days with 0 COVID cases and just the occasional 2 or 3 that pop up. And it's often people that have crossed the border at some stage in the recent weeks. In Australia, currently there's only 685 cases in hospital. And as I said, Victoria's taking most of those. So 662 are actually within Victoria. And there's only 51 cases in ICU and 43 of those are in Victoria. So my actual local experience in Brisbane is fairly limited. Queensland, the state I live in, has only had 1,000 or just over 1,000 cases and 6 deaths. And we had 3 admissions to our Royal Brisbane ICU, and 2 of those patients were ventilated and 1 was non-ventilated. So I keep saying I've been very fortunate in Australia and in Queensland, certainly to have not been affected to the degree that many other countries. And that's given us much more time, I guess, to be able to review and prepare. And very early on, hearing about the impact that COVID was having in China and Italy and other parts of the world really made me start looking for that information and try and start preparing for my local hospital. And among the many resources I was looking at, I couldn't see that there was resources suitable just for physiotherapy. So that's when I really started collating all the information, pulling info from various relevant documents. And then we've got a good network of physios across Queensland. Queensland's quite a large state, but we have regular meetings with senior physiotherapists. And through linking in with that group and also an academic group that involved Australian physios predominantly, but also physios from Belgium, Canada, UK, that's where we ended up developing that document that we published in the Journal of Physio on the physiotherapy management of COVID in the acute hospital setting. So that certainly helped us locally, although it's been fantastic that that's gone throughout the world. It really helped us locally preparing our workforce, doing things like you've all talked about in terms of screening, how you're going to prepare your physiotherapy staff for knowing which patients to treat, which ones to leave, what interventions might be required, and then making recommendations about your physio treatment and PPE. Our own physio department experience, I guess, our department services for outpatients underwent significant change with a dramatic reduction in face-to-face services, and telehealth services are very big in Queensland. We're one of the highest utilizers of telehealth, and we certainly have expanded that significantly now, even further. We prepared for additional recruitment of staff, but so far in Queensland, that's not been required. And just a reduction in outpatient services, we were able to utilize those staff to support the inpatient services. We did actually lose part of our department with one of our gyms being taken to support the expansion of COVID testing clinics. Our hospital actually started doing a virtual hospital So many of the COVID patients were actually left to be at home, and they were assessed using telehealth and only transferred if they were showing particular symptoms or deterioration. And then the physio review of hospitalized COVID patients, Danny sort of talked about this a little bit as well, but we did very much still have a role in these patients admitted to hospital, but we're trying to do that not directly face-to-face, finding ways that we could interact with them, again, using telephone or some sort of telehealth or through the walls or through the glass of their rooms, and primarily looking at functional reviews and maintenance exercises. And very few of the patients on the wards needed anything from a respiratory perspective. Our ICU patients, 2 of them were long-term ventilated, and they did have significant deteriorations in oxygen, that typical pattern of sort of after a week. Both ended up being in ICU for greater than 30 days. One had a tracheostomy. The time to tracheostomy was very long, so they had ETTs in. One was extubated at about 30 days. Similar to Heidi, we had no ECMO. We did use nitric oxide and proning, and both required quite prolonged dialysis. Our physio was limited initially, but we did become more involved once secretion retention. So physios in Australia do that sort of respiratory therapist role as well as the mobility. So for us, one of the first times we became involved was actually post a prone turn where the patient de-recruited and they felt it was due to retained secretions, and we were asked to become involved there. So we did a lot of our respiratory treatments actually timed around the prone turns and trying to treat both pre and post, and then also be there to assist with the prone turnings. So we wouldn't necessarily do daily respiratory physio in a regimented fashion, but we'd assess each patient each day. We're doing respiratory techniques like ventilator hyperinflation, manual techniques like percussion and vibes, suctioning, and then doing some passive range of motion at that time. We participated in helping with prone turns, but we also found a leadership role there fairly quickly because we do have that great skill set in handling patients and mobilizing. So we found ourselves walking in with the anaesthetists who are all being upskilled, and none of them looking around the room and then all saying, well, we haven't actually done the training, but we want to help with the assist. So we'd very quickly be the person promoted to actually teach them on the run. So you had to feel that confidence to lead. We did do a lot of rehab in the ICU, in patients' rooms, tilt tables, getting people out of bed, standing, marching on the spot. Both patients did go home, but both did require a long period of inpatient rehabilitation. And our non-ventilated patient, he was only in there for about 4 days, and he primarily just had a dry cough. So treatment with him was more focused on functional review and looking at how his dyspnea and oxygen saturation were limiting. So although our experience is very limited, and we do feel, again, very fortunate here in this part of the world, I definitely share all those things that you've talked about, that nervousness around PPE and airborne precautions, concern about transmission of COVID to yourself, but also to other colleagues. So I guess there was a little bit of reaction to, oh, Pete's the guy that's always in ICU treating these patients. So going down to the tea room sometimes became a little bit of a concern for other colleagues, but also, your family and taking it outside into the community. It's been great educationally for our team, and seeing it's really helped develop skills in both our junior and senior teams. We definitely felt valued by our intensivists and team members, our nursing team. And I guess the last thing I just say is the experiences from our colleagues in Victoria, where they are having to increase their capacity. Some sites, again, have initially reported quite limited input because of that concern about transmission and PPE levels. But as the number of cases increase, they've really realized that importance of physiotherapy being in there and starting that rehabilitation component quite early. Bed block has been a big issue. Nursing homes have been closing, and those patients have been taking out rehab beds. So it's been very difficult in Victoria to get patients into rehab for that. So similar, again, discharging patients from the hospital to home. And the last thing I'll say is our Australian flu season is almost non-existent. I think this has been seen in other parts of the world as well, but normally at this time of the year, we're reporting about 5,000 cases per week of influenza in this area. But for the whole year so far, we've barely had 5,000 cases. So our flu graph is absolutely trickling along at 0.
Okay, Peter, good speech, and it's really curious now when we hear different settings and we see. And Heidi told she was jealous about Johns Hopkins because of all the available and resources, and I think I got jealous about the low number of cases and no low number of ICU beds and deaths. We have here in Brazil about 1,000 deaths every day, and we have more than 100 dead people with COVID-19. For example, I stay in an infectious disease hospital here with the students from the university, and we had a 7-bed ICU, and we had to change the hospital, and the hospital is with 57. First of all, we opened 25, and then we opened more 25 beds, ICU beds, and we had like 60 or 7% of the patients in mechanical ventilation, and we had about 50% of the patients in prone position, and it was really hard to deal with all this changing. And we had a great time to prepare, but I don't know if we got prepared enough. I don't believe we got to think that we're gonna reach that level of numbers of cases and deaths. And so it's really great to hear that we have places that deal with low numbers. And even though you were really prepared and all the team in the hospital and all the procedure you have was, if you have 1,000 patients, you were prepared to deal with. So it's really great to hear it. And then now Vitor Hugo, tell us a little bit about how it is in Portugal. We have talked once before. Me and Vitor Hugo, we have done a live at Instagram about early mobility with COVID patients right at the beginning of the disease. And let's see if we have changed from there, Vitor.
Hi, very well. First of all, thank you so much, Saint-Clair, for this invitation. It's a great pleasure to be here amongst such distinct colleagues. And I think I would begin talking about something that Heidi said, that perhaps this is a big challenge in the public health department, because we in Portugal we had some time to prepare after what we saw happening in China, but mostly in Italy. And Italy is quite close to us, even in language, and people were quite scared of seeing the footage from in television and Facebook and all the media about what was happening in Italy. Not only the general population, but we as physiotherapists were listening and were reading all that our colleagues in Italy were writing, and it sounded quite catastrophic. So we really began to try to have the best response possible when it appeared in Portugal. So we had that time, which was a good thing. We still try to maintain that public health importance and the measures that you should use, the measures that we should maintain, like wearing a mask or all of the washing your hands, all of that part. We're still having some challenges in the ICU setting. So I work in a general medical surgical intensive care unit, and we quite soon began wearing masks, including even in the outside part of our intensive care unit. And the scariest part, I think, in the beginning was seeing it all happening. So there was this momentum where we had no cases, but we saw what we kept in touch with our colleagues, and then we began having patients and began having cases, and you begin having a patient in an isolation room, and then you have the 3 isolation rooms with COVID patients, and then they are not enough, and you have a red zone and a cluster that is a red zone, and you have to fully equip with the proper PPE and the complete PPE to enter that red zone. So you are not only working with those three patients, but with all of the patients. And we were using 4-hour rotation periods inside of the red zone. And our reality as physiotherapists in Portugal is quite different from it's a little bit different from what you were saying. We have a role in the respiratory therapy part, of course, also in the early mobilization, but also in the mechanical ventilation. So what we would do would be we would use that 4-hour period to try and give the best that we could to our patients. To some of those were the ventilation part and the titration of the ventilation. Some of those were the proning, and we worked directly with all of the team in the proning decision and the act of proning itself. But we had all of these responsibilities, which was quite interesting to see, because suddenly all of even in the media, in the Portuguese media, we are quite well known in Portugal, the physiotherapists, but mainly because of the sports physiotherapy and the musculoskeletal physiotherapy. And suddenly everyone was interested about the importance of our role in the intensive care unit, from the mechanical ventilation to the early mobilization, to the importance of the functional training and trying to give our best on that department as well. So we gave, all of us in the intensive care unit gave a lot of interviews and were approached by newspapers and the television to try to share a little bit more about our role in this department, which was that was quite useful for us and interesting, because we have been doing this for a long time. I have been working in the acute setting for the last 15 years. I've worked in the emergency department, in the neonatal intensive care unit, in trauma, in the trauma center, in the trauma intensive care unit, and now in the last 5 years in this medical surgical intensive care unit. Also, we don't work directly in the intensive care unit, as Danny said. I sometimes talk with Dale Needham, and he's amazing, but we work directly with the intensivists and with the nurse team. We do a morning reunion every day, and we work really as a team. That's one of the most important parts, and I think that's one of the cornerstones of our success. We had 2 patients that unfortunately died, but they all had some bad prognosis, and we had really interesting cases with amazing results, quite like what Heidi said before. Related to the physiotherapists in the intensive care unit in Portugal, we soon began to try and develop some proper training and developing a bank of physiotherapists that could be used by the hospitals that had some kind of experience in acute care, whether it was ICU, but also in the hospital setting. So we developed really early on a course, an online course with some of the most experienced and senior physiotherapists in Portugal, and we had more than 500 physiotherapists from Portugal. As you know, Portugal is a really small country with a little bit more than 1 million of population. So we had this course being attended by over 500 physiotherapists, which was quite interesting. We also provided this course as requested to our colleagues in Africa, in Cabo Verde, and we discussed. Some of us discussed this. Try to provide some education and to transmit our experience to other people as well. And we were in a few webinars. That was, for instance, where I met Saint-Clair in really interesting live about these situations. but mostly we struggled then with a pretty bad first wave that is now past. We have now kind of like a month ago, we had an outbreak in Lisbon, and we were all quite concerned because we were already in the stabilizing phase, and we had an outbreak in Lisbon. But now we had some good news. We've been having some good news. 3 days ago was the first day that we had no deaths related to COVID-19. 3 days ago, so we are now quite concerned about the second wave. We are now experiencing some rising of the numbers, but we are still prepared. Our intensive care, in my hospital, the intensive care units provided or were enlarged, were added some beds, I think perhaps 30 to 40% per ICU. And we prepared an extra ICU completely filled with everything that we needed, from ventilators to renal support to everything that never got the chance to be used, which is quite good. That's good news. We never completed, we never had the lack of ventilators or any other kind of technical support. The main challenge related to the mobilization and the functional part was trying to provide our patients with the best response in the lack of all the equipment that we usually use. So we use cycloergometers and some electrical simulation. And in the first part, we tried to do all of that without using the technology and being mostly creative about it. So I got to know that a bag of renal support weighs, you've got two kinds, one that weighs 4 kilos and one that has 5 kilos, and you use it as a resistance training for some exercises. We also have one of the best views in Lisbon. If my hospital was an hotel, it would be quite expensive because we have a beautiful view of the Tagus River. If you don't know it, you should. You should come to Portugal because it's a really beautiful place to visit. And I got the chance to even take some patients to see that view and to do some exercises doing this. And that we gave, one of our patients gave an interview for one really well-known magazine in Portugal. And that was one of the things that he mentioned, that it was really interesting in all of that context, our attempts of proximity, because we all discuss dehumanization in intensive care, and it's really complicated to develop a connection. We are all physiotherapists. We deeply connect with our patients by touching them and by contacting, by manual contact. We are all physiotherapists, so we all feel this. So sometimes it's difficult to have or to interact with our patients in full PPE. So we try to develop some or to use some strategies. For instance, we had our name in our equipment, so they could know who we were. So they knew who the doctor was, who the physiotherapist was, who the auxiliary or the cleaning lady was, because it's really difficult if they all look the same. And also we tried to maintain one video call per patient to their families, because we didn't know at the beginning what would the outcomes be. So we didn't know. We had all those numbers that all of you discussed prior, that were really catastrophic, with percentages of death really amazing, really high. So some of those patients, we really didn't know if they would be able to see their families again or not. So we tried to also develop that part pretty well, and we had a video call per day to all of the families. So that was also something that we tried to do. Regarding specifically about the condition, the COVID-19, we tried to, in the beginning, the indication, or it seemed like the indication would be to ventilate early, and we tried to do that. We received the patients directly from the emergency room or the place that they were coming from, directly ventilated, so intubated and ventilated, and we tried to extubate them as soon as the inflammatory pattern began to lower, and the patient had the ability, obviously, the ability to support full ventilation by themselves and to properly protect their airways. So, and we had good results. We extubated quite early, and we got the patients. For instance, we got the patients out of bed in a median of 5-point-something days. And but we experienced also another thing, that was the fatigue associated with this condition. 100% of our patients mentioned, even after the ICU, having improper or a strange feeling of fatigue even after their leave from the ICU, leave from the hospital. One of the other parts that we assessed, and we constantly assessed that as physios, was the muscle mass. And I, in my experience, never seen someone lose 45% of muscle mass in slightly over 10 days. I've never seen something like that, and I saw that in COVID-19. I don't know if it's related to the inflammatory pattern. Perhaps it was, and the catabolic condition, the exasperated catabolic condition that these patients were on. But we saw this pattern of losing of muscle mass and ICU acquiring weakness, perhaps happening faster than on other ARDS patients. So this is our experience. I think we will talk a little bit more further about some more specific parts, but mainly this was our experience in Portugal.
Great, Vitor. Great to share with us. And I think that we all, at the end of the speech, we understand that the main goal for the physical therapy is the same, is to give you functionality, and who deals with the respiratory part spend more time doing that. So sometimes it is the price you have to pay to get better respiratory patterns. So you start stepping away from rehabilitation. So I'm gonna change a little bit the order we told, but I'm gonna ask you, if was there possible to deliver rehabilitation in the ICU setting for these patients? Some of you have already started about it, and also because Vitor told us about the fatigue, and that's really common everywhere with these COVID-19 patients. So I would like to know if that was possible to deliver acute rehab for this patient, and what were the main signs you observed in the COVID-19 patients during the ICU stay, or that you have heard about during the ICU stay. I'm going to keep the order so someone doesn't get too long without speaking, okay? So I'm going to bring the word to Daniel.
I think fatigue was definitely one of the things that I put on my list to mention too, especially for those patients who were transitioning out of the ICU and onto regular medical units. In the ICU, kind of as Heidi talked about, these patients were undergoing tons of sedation and having medical processes and medical complications that outlasted many of the other patient populations that we're used to seeing, patients who are on strong sedatives for 3 to 4 weeks, as opposed to 1 to 2 weeks or less time, and things that we've spent a long time in conjunction with some of our intensive care colleagues trying to decrease the use of those medications. And so a lot of that critical illness weakness coming out, and things like not even being able to hold their head up, and working on very minimal postural control, using some of the technological features of some of the beds we have available to just get people into upright positions. Peter talked about tilt tables to help with the hemodynamic changes that people were experiencing. And then the other thing that really comes to mind as people were regaining some of the ability to move on their own was the tachypnea and decreases in oxygen saturation. Our colleagues who do a little bit more of the respiratory part of their care can probably speak a little bit better to this, but they've had large changes, and due to the infectious nature and the inflammatory nature, large changes to their lung structure, their muscle structure that is allowing patients to be able to breathe normally. And so we were seeing a lot of patients who only tolerated short bouts of activity that lasted less than 5 minutes sometimes before they were really breathing very heavily and not being able to retain their oxygen saturation. So those were two of the big things as people started to move a little bit more on their own that we really had to keep an eye on, was their fatigue level and how that related to their ability to maintain their oxygen saturation.
Great. And I think that one interesting thing that we have a lot of tools to assess and to monitor the patients in the ICU setting during the mobility programs. And we have got back and brought to the ICU the Borg scale, the breathless scale, because of this patient that they have so much respiratory impairment. So we needed something that we could use to prescribe the exercise and to limit the exercise. So how far should I go with these patients? And then I would ask you, Daniel, what tools did you get to use with the ICU patients with COVID-19? Did you get to use the same tools for assessment? For example, what have you used? The FSS ICU, or have you used the PFIT? Which tools have you used inside the ICU with these patients?
So definitely the FSS ICU. That's one measure that was sort of started with Dr. Needham at Johns Hopkins. And so we try to use that on all of the patients that we have in our medical ICU. So that's a standard of practice for us. And I'm going to put a little plug into the APTA, who recently published in June an core outcome measure set for patients who have COVID-19. And that includes an MRC scale for strength testing. It includes the SPPB, which is a short performance physical battery, which has balance and gait speed components, as well as a repeated chair stand. And so those are some of the measures that we've been trying to incorporate. And the nice part about the measures that have been talked about, the PFIT, in addition to what you said, don't require a lot of equipment. One of the things that Vitor said was we weren't able to bring the things that we usually work with in the beginning of this pandemic into these ICUs with us. And so we had to be creative on how to assess these patients with less technology and more sort of hands-on techniques that don't require the same level of equipment. So.
Okay, great one. And let's see, Heidi, how was with you to assess this patient, and which were the main things you observed with these patients that were barriers to the mobilization?
Barriers?
Yeah.
I mean, the barriers were the initial phase, which is the very low tidal volume, assist control, mechanical ventilation that they required to protect their lungs, and deep sedation. And therefore, I was not getting into the room nearly as early as I'm accustomed to, because I really could not do anything for the patients. And since our nurses and our respiratory therapists really handle that phase of everything in terms of passive range of motion and respiratory care, I don't need to be in that room, and that's fine because my skills are needed elsewhere. But as soon as our patients on ventilators are able to be switched from assist control to pressure support ventilation, that's when we tend to start physical therapy in the ICU for our COVID patients. Okay. So now the patient is initiating every breath on their own, and they are in control of the tidal volumes that they're taking on the ventilator. Before that, we're really not very much involved. So it was a big change for me to be getting in there much later than we did in the past. And I very much thought that that meant the outcomes would be bad, that these folks would require a very long period of acute rehabilitation after they left the hospital, and the recovery would be months and months and months long. And I was very pleasantly surprised to find out that they could tolerate a lot of intensive physical therapy still in the ICU, right when we switched them to pressure support ventilation. In the very early initial phases in the ICU, when they're very first switched to pressure support ventilation, I think more because of we're carefully weaning off the sedation, the heavy sedation they've been on, and that process on top of the COVID and on top of the prolonged ventilatory time, they do some pretty wacky things. So they are tachypnic, they are tachycardic, they don't necessarily respond well to mobility, but I think what we have not talked about that I end up focusing on almost more than anything is the brain. So the levels of delirium, the levels of psychological trauma, the levels of cognitive and apraxia and neuromuscular issues I found were much greater than I anticipated they would be. And I have to work through this a lot. So it's, yes, they get tachypnic. Yes, they feel fatigued, but I feel like there's also a very large cognitive component to that and a very large psychological component to that. And I've devoted a lot of energy to continuing delirium reduction strategies and cognition and psychological support, and telling them to teach themselves that you've now adapted to horizontal and you've adapted to an anti-gravity state. And your brain thinks that being upright is something very scary. And you're responsible, patient, for telling yourself that upright is not scary. Yes, we're going to, and we give extra respiratory support, right? So we add extra pressure support to our ventilatory settings when we are working with patients. We give them extra oxygenation when we are exercising them. So we want the work of breathing removed. We don't want them to get tachypnic and having all their energy focused on the breathing part. We want their energy focused on them working their legs. So my whole goal is, you're going to get out of bed to a chair and you're going to stand up as soon as we possibly can. And I've been amazed at how quickly we can still make that happen with our ventilated patients. We use the FSS ICU. We use muscle scores. We use a functional mobility score that we developed for ourselves at UCSF. And that's mostly at the ICU level what I can use. I can do the sit to stands and the SPPB, but typically I wait until a COVID patient's on the floor before I'm doing that. We also have a number of ICU patients who are COVID who are on high flow oxygen and don't end up being intubated. They're the ones you can do more of the SPB and the balance and the higher level kinds of outcome measures on. And they obviously don't tend to need nearly as much psychological counseling or as much cognitive intervention as do the venti patients.
And that's really good to hear. I know you have talked about at Twitter, you have talked a lot about it. You have published a recent editorial about the ICU liberation. And when we think about the measures to develop the ICU liberation without damage to the brain, to delirium, we are dealing with patients that are not able to go through all the process, that you need to stop sedation early, you need to take them away from the ventilator early as possible, and you need the family engagement, and all that. It's much harder on the COVID-19 patients. So that really brings us the idea that we're going to face a real problem about psychological problems with these patients. I don't know if you feel the same.
No, absolutely. So I'm starting my A2F bundle interventions much later than I'm used to, and that's what I'm talking about. But you still have to do it. So we have some patients where the family is on an iPad on Zoom, through the entire PT session and beyond. And it makes an amazing amount of difference. You know, it's not me, it's not my face in front of them saying, come on, you can do this. We know you can. I know it's hard. It's their wife or it's their little child. We have so many children on the Zoom screen, and I'm often behind the patient, you know, giving them facilitation and stretching them and supporting them, and their little child or grandchild on the screen right in front of the patient, and I'm looking at this little child speaking in Spanish, you know, te amo papa, and I like have tears coming down my face behind this patient because it's so moving. And then they get better and they go home, and you know, it's so hard and sweating and exhausting and stressful to be in the room with these patients and yelling through all the PPE. And at first I thought, is this even worth it? These people are gonna die or go to a nursing home or something? What are we doing? And then when I watched them get better and return to their families and wow, recover amazing amounts of function, like not our other patients do at all, much better, in fact. The reward is just as great as the amount of stress and sweat you give in that early intervention.
That's really amazing how we need to reinvent ourselves to give to the patient everything that the patient really needs. And I think that was great with the physical therapy. I think we developed a new way of giving physical therapy, giving functionality, and bring the patient back to, when we talk about the ICU, of course, we need all the procedures, but we have patients that most of them were walking when they got to the hospital. So we need to give them back to the community, to the society walking. And let me see with Peter. Peter, and you said something really interesting in the document about the recommendations, that it's dealing with the team, that you need to make steps with the senior physical therapist and the leader one, and how does that should improve the assessment and the physical therapy and the real therapy for these patients in these conditions that we are talking here.
Yeah, I think the senior involvement has been critical, particularly as you're, relying on a larger contingent of physiotherapists. We're similar to, I think it was Danny who said, we've got a large proportion of our staff actually trained to come and work in ICU, both for respiratory and rehabilitation work, but their exposure might only be, a couple of weekends or an on-call shift. So having that senior support there, I think, is always critical, and looking for those signs of when we can start to engage and trying to overcome the barriers. The story that I have been telling is even getting a tilt table into an isolation room required senior support because, it doesn't actually go through the antechamber without some manipulation and putting tilt table actually up into an upright position first and then going through the doors. So, simple things, problem solving, all those little things that come up, I think are very essential. But we've certainly seen very similar things as well, with even amongst that small cohort that we've had, that extreme fatigue where patients looking quite good and settled in the chair, and you think this is going to be good to be able to stand and mobilize, and you get them on their feet, and then that fatigue just seems to crunch in really, really quickly. The tachycardia. We also had another patient who actually had some sort of myopathy, cardiac myopathy develop. So he had prolonged symptomatic hypotension that limited his mobility. So I think it's there's definitely this extra element or more extreme element of fatigue amongst this population, but I think we still have to recognize there's a lot of individual variation. And you will get those patients that do get up and get going fairly quickly, but those other ones that do require a lot more of that rehab, whether that's because of their fatigue levels, the amount of muscle loss that they've had, prolonged delirium, all those things that we normally talk about. So I think we've subsequently used quite a variety of our rehabilitation strategies. we have always tried in our unit, we've tried to actually get in and get involved pretty much similar to what we'd do with a normal patient in terms of our timing for rehabilitation. But I know there's definitely been across Australia, within Queensland, those units where the physios, even if they're keen, have not been allowed to get in, and that's been difficult to, I guess, get around initially. But that's helped with advice and coaching and experience. But also just that access to equipment, I think, is one of the things that came out earlier in terms of what equipment do you take in and what do you leave out. Even taking a chair into the COVID areas, and then if that chair needs to come out, people are concerned about that chair and how many times you've cleaned it. Have you cleaned it properly? So all those little elements. And I think it is important to try and use things. Vitor mentioned that I never looked at dialysis bags before, and I will now think about that. That's great ingenuity. We've used TheraBands, and I always traditionally take more of a functional approach to my mobility. But we do have access to things like FES and motor meds, but typically I do prefer a more functional style myself.
Yeah, that's something that brings me to a question that I have received a lot from the physical therapists here, and we have had the opportunity to train new physical therapists that were hired to deliver physical therapy during the ICU. And one of the main questions was, when do I have to start the physical therapy with my patient? And I remember that if you go through the documents and through the articles and papers, and they are just the same recommendation as always. You have to start as soon as possible. And I don't know what do you all think, but I don't think we have changed that. We need to start as soon as possible, but we need to be with the right protection, and we are going to have a barrier that's the extremely high sedated patients for a long time, and that's going to bring us more difficult, because if we think about passive range of motion, it would be much better if we had resources for that, for good results, than just our hands, or we would be like all day long doing passive mobilization, and that wouldn't bring a lot of good results. So I remember when I read the document, and that the document said, well, you need to understand the patient. If it's going to put the physical therapist in risk, then it shouldn't be the right moment. But if the patient needs, if he has signs that he's going to be with functional impairment, then we should start dealing with these patients. And go on, Peter.
Saint-Clair, I think even one of the things that we were seeing with prolonged sedation, just that tightness across the chest from that respiratory perspective. So typically we'd do more of it with our spinal patients, putting them in sort of a crucifix position, but we were doing that for these patients just to get that chest wall expanded a bit more and try and maintain some of that shoulder range. And that was all done with that heavy sedation. So I know there's not a lot of evidence for passive ranging as such in our ICU, but we definitely we're still continuing that even once the patients were waking, and when they were giving us the feedback about what that felt like getting that stretch, they definitely appreciated that it was doing some benefit.
No, and in that stretch, let me just grab that for a second. That stretch also changes something that we as physiotherapists, I think perhaps we should try to upgrade our knowledge on, which is hemodynamics and cardiac responses, because we know that COVID-19 really took a toll in the cardiac part, and we know that. It's been well documented. And so we as physiotherapists, because we really challenge the hemodynamics of our patients. So we must have the proper knowledge and the proper tools to correctly assess it. And that's mainly the first thing that I wanted to share with you guys, that these notions, sometimes we physiotherapists are really related to the musculoskeletal parts and the respiratory parts of the lungs and the muscle, the inspiratory muscles and expiratory muscles and cuffing and that part, and the hemodynamics is something that we really must be quite aware of. because of scales and measures of assessment, well, I will tell my bias on favor of CPACs. I think CPACs is one of the most amazing scales that we can have because of three reasons. Because it gives us a proper and an adequate information about the respiratory part, whether it's on the respiratory support, but also on the capacity of the patient to protect its airway. That's an important part, but also about the functional part and the ability of the patient to be able to perform a lot of tasks on the functional part, and the strength part as well. One of the equipment that we have every day on the red zone was the dynamometer, and I will mention again the importance of the ultrasound, because of the equipment we couldn't auscultate our patients. So the assessment, the thoracic assessment with an ultrasound was an important way to perceive the evolution of the respiratory part and of the pneumonia associated with the SARS-CoV-2 infection, but also on the muscular part and the muscular assessment. So we use the CPACs and the dynamometer on the patients that could use it, the dynamometry and the MRC sun on the patients that were able to cooperate with us, and the sedated patients or the patients that were unable to cooperate with us because of delirium, because of some other condition, we would constantly use the assessment with ultrasound. So those were important weapons in the assessment of these patients that I think, and that the literature quite mentioned it quite a lot, that are good tools to use as physiotherapists in this setting. And then again, as Peter was saying, we had to be creative, and the bags were we don't have tilt tables here. We didn't brought them to inside of the red zone, of the infected zone, and even a chair had to be discussed. Because the chair was an issue, as we all were issues, because in the beginning, outside of our intensive care unit, I think all of us suffered from some stigma associated with those patients, because we were treating these patients, and we didn't know how it would work out. So we were all concerned about our families and our colleagues and the people that we interacted with, and the other people were concerned about interacting with us. So that was also an interesting part. But I think, responding to your questions, Claire, I think I will then again mention my bias on the CPACs. I think the CPACs is an amazing scale, and it's got something that perhaps other scales don't have. That is, you look at the graphic results, and you instantly see an evolution or the need for a specific kind of intervention, whether it's respiratory, and in the respiratory part, if it's in the ventilatory part or in the protection of the airway part, and then again on the functional part and on the strength part. So it's quite visual, and that assessment is really interesting. And we also use the RP, and we brought the Borg modified scale again to the intensive care unit in order to monitor our patient perception of exertion. And but also our patients responded, as every one of you said, with sometimes with tachypnea, almost every time with tachycardia. So the challenge was to provide the best exercise and the best mobilization to that patient without having a toll on the hemodynamics and consequences on that part, because we know that we must have some anabolic response, and perhaps we won't have a good result in a system in acute inflammatory situation where the catabolic state is the most important part, and we won't be able to build muscle in a severe catabolic state. So those, I think, were the more important questions about situations about the assessment and specific part about the cardiac part and the hemodynamics that I think we as physiotherapists really took a step up with this context of COVID-19.
Good observation. And I think that one thing that's really important is the way that the ICU is programmed that has its beds. So I know that Vitor has an open space, and I know that the United States, I think in Australia also you have rooms, and then you get it's really hard to take a device, a tool from one bed to another one. And when you have an open space, we also have open space here with a lot of COVID-19 patients, but with distance from each other. But it's easier to carry one tool to a lot of patients, and you have the proper cleaning way to do it. But we don't need to take from one bed from one room to another room, so that makes it a little bit easier.
Yeah,
And
what we did was we had an open space, as you said, because we mentioned it before. We had an open area with negative pressure, with controlled pressure. So we fortunately we had the time prior to having the patients, the infected patients, to test all of this and to make the upgrades that we needed to do. And I think that was really important in this context.
okay, and we have put all the questions together almost, and I would like to hear from you if what was the biggest challenge you had, and what did you get to learn from the COVID-19 times, the pandemic times for the physical therapy? What was most important, and what was the most difficult thing you had to face? And now talking a little bit about profession, and you can include it if you had. No, for me it was really difficult because we had to change protocols and to train all the people. Or was that the tiredness, and like Heidi said, it's hot and get sweat and you spend more time with one patient? What was the most difficult things, and what did you get to learn more about it? What do you think that's going to stay with us as a physical therapist from here to the other times that you're going to face? We can start with Daniel also.
I think we've all touched on what some of the really difficult pieces are, and I think when you take each individual one of those, you can find ways to sort of cope and strategize around those things. But the fact that all of this came and happened so quickly, whether you were doing training to determine whether your procedures may or may not work, or you were learning on the fly, as our department like to say, we were building the boat or building the plane while we were trying to fly it, and trying to do all of those things at one time and keep your staff safe while still providing high quality care to your patients to the level that has become expected, was probably the most difficult thing, was trying to fit all of the improvement into that in such a short period of time. But what I kind of touched on earlier when I opened up the presentations, I think one of the best things I learned about our profession is how adaptable and creative we really can be. And the tools that we have as physical therapists, especially as therapists who work in hospitals and in intensive care settings, is most of the tools that we need to succeed, we already have in our head. And I think our ability to adapt what we already do and use on a daily basis to this situation has really demonstrated our value as a profession to a bunch of people in the hospital setting who may not have recognized that beforehand. And I think that's one of the most positive things that has come out of this pandemic, if you're going to pick one.
Okay, Daniel, thank you. Heidi, what do you think that was most challenging, and what do you think that you have learned most from the situation?
Challenging for me is to have our families not be at the bedside. I saw that coming as soon as we had our no visitor restriction put on us for our COVID patients. That to not, I use the family for everything I do. I get them to really be the physical therapy assistant to a huge extent. And so I miss them dearly. Having them on a screen in the room is not the same at all. That was the biggest, has been the biggest challenge, is to be there without the family present at the bedside. And to allow them to continue doing the things that we need to do to restore the patient as a person when I'm not in the room. You know, me being in a room with someone for 30 minutes is not going to make the difference the way having me in the room and then having the loved one at the bedside for the rest of the hours of the day, and knowing what I would like them to do to continue to facilitate the day-long session of physical and rehabilitative care is really a missing component. And I think what it does for our profession is, I think we are proving that these patients, we underestimate what they can do. That our patients in an acute care hospital setting and in the intensive care setting really can recover well and really can exercise, not just reposition, not just functionally do, you know, something that gets them from a bed to a chair, but they can exercise and they can benefit from whatever prescription of exercise meets their needs the most. And that we do them a great service by having them exercise while they are still critically ill and while they are still in an acute care hospital, and not writing up an assessment and a plan that says, yeah, they need a lot of rehab, and won't that be great for them that happens when they leave our hospital and they go to the rehab. I really hope this inspires us to be better rehab professionals in this setting and to provide more intensive and more creative types of physical therapy in this setting. And then the last thing I hope it really does for our profession is make us known, and make it known that if your loved one's in the hospital, ask for where's the physical therapist, and make it known that we are also really frontline providers. It's not just nurses and doctors. We are really doing a lot for the patients, and the patients know that, and the families know that. It would be great to see the public know more of that. So I hope that that's one thing that happens for us in the future with this diagnosis.
Good observation, and I think that we are all hoping that it stands forever, this importance that the physical therapist is receiving, that we are showing also the other physical therapists and the population. And we got to learn how to show it with good results. Peter, and what about you?
Look, yeah, I think everything that people have been saying is absolutely, I'm in full agreement with. And I guess one of the big things from a practical perspective has always been around the PPE and what is seen as safe PPE for physiotherapy. And I hope that we can, over the next, I'm sure it's going to be a year or two, actually make some inroads in that, particularly around our respiratory therapy. But it also does touch on your mobilization and rehabilitation that you do, and what is appropriate PPE, particularly when you're doing those heavier patients, where you're having to get very close and very physical in terms of proximity with the patient and hands-on. And I guess there's a lot of unrest on that topic still. There's papers being published talking about your aerosol generation versus, whether things are droplet versus aerosolized. So there's still unknowns in that area, and that has been challenging to, as different groups of clinicians within the hospital make decisions. We had our ENT surgeons and anesthetists and intensivists being quite strong and vocal and telling our profession what we should and shouldn't be doing. But it was actually out of out of sync with the advice that was coming from the infection control team within the hospital. So managing some of that amongst the physio team, and then within the actual medical team and nursing team in the ICU has been a challenge for sure. Lessons learned, I think there's been many. Again, it's very nice to reflect across our profession. And I think it's been amazing to see how much professional development can actually be delivered locally, statewide, nationally, and internationally very easily. And Vitor, you've got me on the numbers via your weekend course or whatever it was. You know, being able to do, I think it was 500 that you said, is just fantastic. We had a similar thing within New South Wales Health and doing video conferencing to about 300 people. So that was something I've never been involved in. I was very nervous about doing, but it proved to be very, very effective. And we've certainly had greater involvement within the pandemic planning within the hospital. And I think getting allied health on those pandemic plans will be something that we see a lot more in the future. And really looking at how our workforce can support nursing and medical workforces, but also do their own thing, their business as usual. The big thing I've also seen is just the combined efforts and teamwork and how much that can achieve big things in a short period of time. And I just reflect on that article that we wrote that, as we've said, has gone out worldwide, just the amount of effort that went in from a group of people, and it had much bigger impact than I ever thought would be possible. So I think it really does show all of these things that international physiotherapy or physical therapy profession is super strong.
Great, Peter. Great. Thanks a lot. And Vitor?
I think we all agree
Share your
that
thoughts.
that one of the most challenging part was having a PPE, a full PPE during a 4-hour period with all the dehydration and with all the tiredness that you get, because working with that suit, working with that equipment is not the same as working with our regular suits, and it really takes a toll on your energy as well. It's not just the patients that get fatigue, you get some as well. And I don't know why that is. I don't know if it's because of all the sweating and all the dehydration associated with it, but I experience myself a lot of tiredness, a lot more than usually. And well, one of the other challenging parts was trying to develop, as Peter was saying, thank you so much, training all of those physiotherapists in some high value approaches in the intensive care unit, so that it was clear that we deserved that PPE, that we had something to give to our patients that no other professional could provide, and that would change the outcome in a really important way. And all of the papers that were released on the physiotherapy part, but also all of in other media or in mass media, not only in evidence based literature, but also the view of the population, of the general population, of the importance of the physiotherapist in this setting, not only on the intensive care setting, but also on the post hospitalization associated with this. And we got a spotlight. Suddenly, it's like Messi said, we worked for a lot of years to be an overnight sensation. And I began working when I was 4 years old, but I've been working for the last 15 years, trying the best that I can. And it's really interesting to see that suddenly everyone is interested in physiotherapy, and everyone is interested in respiratory physiotherapy, and the functional part, and then the exercise part, and the early mobilization. And that's amazing. All of these information, of these news that constantly come out are really, I think, all of this awareness about our role, I think that's a really positive part about all of this. And I hope that we stand up for it, and we always try to keep doing our best and keep providing our patients with high quality, with high value interventions that really changes something in function, in mortality, and in quality of life. And I think that's the challenge for the future, that we can provide the best strategies to our patients that are really worthwhile.
Also good one. And I would like also to share a little of my opinion. I think that I have had the most intensive studying months because everything was so new and we wanted to give the best physical therapies for the patient, and we wanted to share with our colleagues, with the other PTs from our setting, our servicing and other services as well. So we started studying and studying to find out what was really important. And at the not at the end, because we're not at the end, really not. And but we have learned a little bit that we talked about that in the beginning, that what we do now, it's not different from what we did before. I mean, the main goal of the physical therapy, the main outcome is to give back functionality, and everything has told about that. And we have also observed that it's possible to deliver that to this patient. I think that the post ICU recovery is getting highlighted right now because most of the cities and the countries, they are getting lower numbers. And so these patients are getting out of the hospital. We are start to understand and being able to save more lives. So we are getting these patients and giving them back to home. So that brings much more evidence for the physical therapy after the ICU setting. But we deal with ICU setting, and we know that the rehab for this patient in the acute care setting brings a better result after he gets discharged from the hospital. If we don't do that right now in the ICU, we are probably not going to get recovery after the patient gets out of the ICU. So I think that we got to show and we got to learn and we got to share experiences and to understand that physical therapies have always been important to the ICU setting. And we have different times that the physical therapy got inside the ICU. And but we are all developing, and I think we have given a huge step toward a better physical therapy in the ICU. And that depends on all the physical therapies inside the ICUs. But yeah, the biggest challenge is that really exhausting, and we get tired and we get sleepless, and we need to study, we need to be awake, and we need to be in the ICU, and it's hot, and we get scared if we're going to get infected and if people around us is going to get infected, and then we don't know, we have our father, mother, son, daughter, friend, husband, wife, and we get really worried about these people. And with all this challenge, I think that we are going to get good results when we look back. And I think that the ideal was that everything that we are doing now and we are developing and getting better results should stay for all the patients after we get the COVID outside of our lives, especially a little bit outside of our lives. And I think that's the big challenge for the future. Well, we have been talking about almost 2 hours here. I think that's 1 o'clock in the morning in Portugal. So Vitor needs to sleep so he can get back to the ICU tomorrow. And I would like to thank a lot everybody for your time, for being available to this conversation. And it's really important, not just here in Brazil, but it's really important for, I think, for other countries that physical therapies, they change experience and they get to hear each other, so they get to know, well, we are all doing the same thing, we are going to the same goal, and that brings a profession much better, much highlighted. And I think that's amazing for the physical therapy in the ICU setting. So I want to thank a lot all of you for your time here, and I want to open the mic so you can just say your final words. Okay, and I hope we had the chance to get other moments like this to talk about other things on the ICU side, on the physical therapy, in the acute care. I have done it with some people. I have done one time with Heidi. I have done it one time with Vitor, and I hope to have more talks later at other times.
Sounds great. Thanks very much.
Oh, sorry. Go ahead, Peter.
I was just saying, sounds great. Thank you very much for the invitation. It's been a great talk.
I was just going to say thank you very much for having us on. I thought it was really interesting to hear about some of the differences, but I think it was more interesting to hear about all the commonalities that we've seen across all of our practices, which is really cool.
Yeah, the same with me. Thank you so much for the invitation. It was amazing to discuss all of this with you and to share a lot of the concerns that I have that I share with you as well. So thank you so much.
Yeah, I agree. It's really beautiful to see how we have so much more in common than maybe we even think on the surface. So a wonderful blessing to me for meeting all of you today on the screen. Thank you.
Okay, people, I would like to also to thank the people that followed us live on YouTube, and it's going to be able so people can, it's going to be available so that people can watch the webinar later at other times, and I think it's going to help a lot of people. Okay, later we're going to have other webinars here on the channel, and I hope everybody gets to subscribe and participate in it. Bye-bye. I hope you all get to be well and no COVID for everybody.